اول ما اقول لك مأمون نبدا.
طيب تمام.
Live now.
Live now. Start.
طيب السلام عليكم. Good afternoon, ladies and gentlemen. I am Mohammed Mamoun, brand manager cardiovascular at AstraZeneca Saudi. At the beginning and on behalf of AstraZeneca, I would like to welcome all the online attendees from Saudi Arabia and the Gulf countries to the Cardiovascular, Renal and Metabolic Forum. Actually, this scientific gathering was built in response to the current COVID-19 outbreak situation, and also to echo the government and the healthcare authorities' message to stay at home and stay safe. And also it was built to allow all the HCPs across GCC countries to have access to continuous medical education. The main purpose of today's event is to highlight the best management approaches for CVRM disease areas, mainly ACS, diabetes, and dyslipidemia. And for that, we are truly honored to have three of the top experts in CVRM disease areas: Dr. Abdel Masoud Al-Junaidi, Dr. Abdel Qawi Al-Mansari, and Dr. Ali Sultan. Dr. Abdel Masoud Al-Junaidi is consultant intervention cardiologist at Arfan Hospital in Jeddah, Saudi Arabia. He is also associate professor of cardiology at Al Azhar Medical School. Dr. Abdel Masoud's presentation will focus mainly on ACS. Then we'll be having Dr. Abdel Qawi Al-Mansari. Dr. Abdel Qawi Al-Mansari is a member of the American Board of Endocrinology and the American Board of Internal Medicine. Dr. Abdel Qawi is also consultant endocrinologist at International Medical Center Hospital in Jeddah, and he is the chairman of Jeddah Endocrine Club. Dr. Abdel Qawi's presentation will focus mainly on lipid management in diabetic patients. Finally, we'll be having Dr. Ali Sultan. Dr. Ali is consultant endocrinologist, head of endocrinology department, director of diabetes center at International Medical Center Hospital in Jeddah. Dr. Ali's presentation will focus mainly on cardiorenal risk in diabetes or in diabetic patients. Finally, for all the online attendees, welcome again. And if you have any question for the speakers during the presentation, please use the Ask a Question chat bot at the bottom of your screens, and your questions will be answered by the speakers after this presentation during the Q&A session. And for now, I would like to leave the floor and welcome Dr. Abdel Masoud Al-Junaidi to start his presentation.
Presentation.
Doctor, we can see your screen, Doctor.
Yeah, you have the presentation now,
Doctor, just through the share screen button, if you can share your presentation, please.
Okay, I'm trying. Yes, I'm trying. Share presentation فين؟ ليه؟ ماشي اوكي. طيب there is some technical problem كده. I will solve it يا محمد and I will be back within 1 minute only. Okay?
Okay, doctor, never mind. Okay.
Okay.
So welcome again everyone on the line for this online webcast. Just we are waiting for Dr. Abdel Masoud to solve this technical issue, and will be starting the presentation in just 5 minutes. Welcome again, Doctor.
Thank you, Mohammed. I will share the presentation.
Okay.
Host disabled.
Just 1 second, Doctor. They will allow you just right now.
Okay. Okay, you can see the presentation now, Muhammad?
Yes, Prof. Yes, Prof. You can
Okay,
start.
Assalamu alaikum. Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank all the AstraZeneca teams, Dr. Ma'moon, Dr. Islam, for inviting us during this very hard time in the world, in the era of outbreak of COVID-19. And I also would like to thank them for the continuous medical education using the virtual learning education via the internet. So I will start my presentation. I will talk about the management of acute coronary syndrome in 2020 in the era of outbreak of the COVID-19. Actually, I have the chance to add some data about the acute cardiac injury in patients who presented by COVID-19, and it will be mentioned in the end of the talk. So the spectrum of acute coronary syndrome, three spectrum, the SCT segment elevation MI, you can see on the left side of the screen, in a patient who presented by typical resting anginal pain for 20 minutes. And the ECG showed SCT segment elevation above the baseline. So this is enough for diagnosis of SCT segment elevation MI. So this is the first spectrum. The second spectrum, typical resting anginal pain associated with SCT segment depression or T-wave inversion or dynamic ECG changes, and it is associated with elevation of cardiac biomarker, mainly cardiac troponin and CK-MB. The last spectrum, which is unstable angina patient, the typical anginal pain, resting associated with normal ECG or T-wave inversion or SCT segment depression or transient SCT segment elevation. But if you will do cardiac enzymes for this group of patients and came negative, so this is unstable angina. So we have three spectrum of acute coronary syndrome presentation: SCT segment elevation MI, non-SCT segment elevation MI, and unstable angina. In the United States of America, this is very nice. Statistics showed the percentage of presentation by acute coronary syndrome. The SCT segment elevation MI represent about 22% of the acute coronary syndrome presentation, non-SCT segment elevation 50%, unstable angina 28%. All acute coronary syndrome spectrum associated with high mortality rate, but the highest mortality, it is associated with SCT segment elevation MI, and all the data showed the mortality rate in SCT segment elevation MI 50%. So we are treating only 50% of the patient who are presented to the hospital. The other 50% died either at home or in the street. So we are dealing with life-threatening condition, which is SCT segment elevation MI. The mortality in non-STEMI, it's not low, it's high, but less than STEMI, and the unstable angina also associated with high mortality rate. But if you will compare it with non-STEMI or STEMI, it's lower mortality if you compare it with STEMI and non-STEMI. So the main conclusion in patient with ACS by all spectrum, we are dealing with high mortality rate. So this is why the aggressive medical treatment and revascularization is the best and the only option to save the patient life in all spectrum of ACS. In SCT segment elevation MI, as international consensus for management, early revascularization, and there is two strategy for revascularization for patient who presented by STEMI, either to give thrombolytic therapy, and the most famous one, which is TBA, and the old one, which is streptokinase. And still, we are using the lytic therapy in non-PCI capable center. The second option, which is primary PCI, to send the patient immediately to the cath lab to open the infarcted related artery. And the time here, it's very important. For patients who are receiving thrombolytic therapy, the thrombolytic therapy should be given within 30 minutes, not more. And for patient who presented to PCI capable center, the revascularization by PCI should be done in less than 90 minutes to save the heart and to save the patient life. But in patient with non-SCT segment elevation MI, there is 3 division of this patient. Not all patients with non-STEMI carry the same risk. There is mild risk non-STEMI, moderate risk non-STEMI, and high risk non-SCT segment elevation MI. How can we know our patient in high or moderate or low risk? By using risk score. And we have 2 risk scores. The first one, which is STEMI risk score, and there is 7 predictors to calculate the risk of the patient. So if the TIMI risk score 1 to 2, so this is low risk non-SCT segment elevation MI. If the TIMI risk score 3 to 4, 2 to 4, so this is moderate risk non-SCT segment elevation MI. Once the TIMI risk score more than 4, so this is high risk TIMI risk score. Another risk tools to classify the risk of non-SCT segment elevation MI, which is GRACE risk score. And in patient with SCT segment, non-SCT segment elevation MI, if the GRACE risk score equal or more than 140, so we will consider our patient high risk non-SCT segment elevation MI. This 2 risk score, it's available in Apple Store or Google Play, and you can download this risk calculator and you keep it on your phone or iPad, and you can easily go to this risk score to know your patient risk, either it's mild, moderate, or high risk non-SCT segment elevation MI. Cardiac troponin, it's a very important predictor for prognosis in patients who are presented by non-SCT segment elevation MI. For example, if you have patients presented by typical anginal pain, ECG showed the changes, either depression in ST or T-wave inversion, or even normal ECG. And you did 3 sets of cardiac enzymes. And in each set of cardiac enzymes, the cardiac enzymes elevated. I mean, first set elevated, second set double elevation, and third set triple elevation of cardiac enzyme. Those group of patients carry very high risk of mortality, and revascularization should be as soon as possible for this group of patients. The new biomarker, which is high sensitivity cardiac troponin, it's a very good and very sensitive test to roll out acute MI in the emergency department. For example, if patient presented by typical anginal pain and ECG showed normal finding or ECG changes, either depression or T-wave inversion, and you did first set of cardiac and high sensitivity troponin and came negative, second set negative, third set negative, this group of patients carry very low risk, and you can even discharge the patient home and to send it to the outpatient for further assessment. And by using the high sensitivity cardiac troponin since 2009, the reclassification of the unstable angina, by using this high sensitivity troponin, we can pick 22% of patients from unstable angina, detecting early acute MI non-S segment. The management approach for patients who presented by acute coronary syndrome, as I mentioned before, STEMI patient, SCT segment elevation, those group of patients need lytic therapy and primary PCI. And if you will give lytic therapy, the door to needle time should be less than 30 minutes. And if you will do primary PCI in the cath lab, the door to needle time in the cath lab should be less than 90 minutes to open the infarcted related artery. But the management for non-SCT segment elevation MI, there is 2 management strategy. Routine invasive strategy, I mean less than 72 hours, all patients should be went to the cath lab and to do coronary angiography and to open the infarcted related artery either by PCI or coronary artery bypass surgery. So the routine invasive strategy, in less than 72 hours, all patients should be catheterized and should be revascularized, plus the optimal medical treatment. The second treatment strategy, which is delayed invasive strategy, I mean to keep the patient on maximum medical treatment for 3 to 4 to 5 or 7 days, then you will choose some group of patients to send it to the cath lab, and the one who stabilized on medical treatment, you can keep it on medical treatment. But the meta-analysis comparing routine invasive strategy versus delayed invasive strategy showed the following data. This is randomized meta-analysis of 9,000 patients in 7 randomized clinical trials. And you can compare the routine invasive versus selective invasive strategy. And by using the routine invasive strategy, all patients to send to the cath lab versus selective, you can appreciate 18% relative risk reduction of death, myocardial infarction from time of randomization to the follow-up. So routine invasive strategy better than selective invasive strategy for reduction of MI and mortality. Not only the benefit came from reduction of mortality, but the benefit came by improvement of angina class. For patients who are treated by routine invasive strategy, there is 23% relative risk improvement in the angina class. I mean, if the patient in angina class 4 or 3, by routine invasive strategy, complete improvement of the angina status from 0 to 1. So this is another benefit. Also, the rate of rehospitalization in patients who are treated by early invasive strategy versus in selective invasive strategy, there is 34% relative risk reduction of hospitalization, recurrent hospitalization in patients who are treated by routine invasive versus selective invasive strategy. Another meta-analysis, which was published in 2006, showed 25% relative risk reduction of deaths in patients who are treated by early invasive strategy, and more than 15% reduction in myocardial infarction in patients who are treated by early invasive strategy. The latest data showing the benefit of early revascularization in patients who are treated by early invasive strategy, it was published in the Circulation in 2017 and showed the same finding. If patient presented by non-SCT segment elevation MI, the routine invasive strategy less than 72 hours showed superior to selective invasive strategy, superior to ischemia-guided therapy, and significant reduction of MI and mortality, not only in high-risk non-STEMI, but it is extended to intermediate risk non-SCT segment elevation MI. What about if the patient did coronary angiography within 24 hours or less than 24 hours from the presentation? Definitely, there is significant reduction of this myocardial infarction stroke in all patients who are treated by early invasive strategy, and you can appreciate all outcome on the left side of the unity line, indicating the superiority of early revascularization and early benefit of coronary angiography for all patients who presented by high risk or intermediate risk non-SCT segment elevation MI, and the procedure done less than 24 hours. This finding from this 3 meta-analysis give positive impact for the European Society of Cardiology guideline and the American College of Cardiology, American Heart Association guideline to put the early revascularization in patients with non-SCT segment elevation MI within 24-hour priority for all this patient, and this is class 1 indication level of evidence B in both group. So if there is any benefit if the patient did angiography less than 24 hours, yes, there is benefit to be sure 100% by right diagnosis and to get early prognosis, I mean early risk stratification, and to initiate the early management, and the last benefit, which is early discharge. But there is no any benefit in mortality in this group of patients. What about the immediate? Once a patient admitted to the ER, chest pain, proved to be non-segment elevation MI by cardiac enzymes, what are the benefits if we will send the patient from the ER to the cath lab? There is 4 trials. 2 of them showed benefit, 1 neutral, and 1 showed no benefit. So the message here from the revascularization in non-SCT segment elevation MI, high risk, intermediate risk, non-SCT segment elevation MI, angiography should be done within 24 hours, followed by revascularization. And this is the main conclusion: high risk or intermediate risk non-SCT segment elevation MI calculated by GRACE score or TIM-RISK score. All this patient should be went to the cath lab after initiation of proper medical treatment and to do coronary angiography and to revascularize this patient within 24 hours. Aspirin is the gold standard antiplatelet therapy for any patient who presented by acute coronary syndrome spectrum. And all of us know the mechanism of action of aspirin, which is COX-1 inhibitor or thromboxane inhibitor. And the evidence came from here in STEMI and non-STEMI. On the left side of screen, you can see the effect of aspirin, combination of aspirin and lytic therapy alone versus the placebo. The last line, which is brown line, showed the combination of streptokinase and aspirin. And here there is significant reduction of vascular death in patients who received lytic therapy and aspirin during the presentation of SCT segment elevation MI. The most important finding here, if you will give aspirin, it will be as effective as lytic therapy, and this is seen in the in the blue and red line in the screen. And if patient not received any aspirin or lytic therapy, definitely the mortality, it will be very high, more than 50%. Also, aspirin, it's highly effective in patients who presented by non-SCT segment elevation MI, and you can appreciate the significant reduction of myocardial infarction and cardiac death in patients who received aspirin upon presentation to the ER. Which dose of aspirin it's effective? All aspirin doses, either low dose or high dose, are effective for platelet inhibition. And you can appreciate higher dose 500 to 1,500 and the lower dose, which is 75, all showed the benefit for reduction of death and MI. So what are the difference? The difference here, the bleeding risk. If you will give higher dose, you will get a platelet inhibition, but you will get higher bleeding. And if you will keep the patient on low dose aspirin, which is 75, 81 or 100 milligram aspirin, you will get the same effect of higher dose, but you will decrease the incidence of bleeding. Combination of B2Y12 inhibitor with aspirin, either low dose or high dose, it will increase the bleeding significantly. But definitely, if you will use high dose of aspirin plus B2Y12 inhibitor, as mentioned here, clopidogrel versus aspirin, definitely you will give double or triple elevation of bleeding with combination therapy. But there is some clinical issues with aspirin here, which is treatment failure, I mean aspirin resistance, and this is related to the either to use enteric coated or non-enteric coated. There is some drug-drug interaction, COX-1 related pathway, medication non-compliance from the patient, and premature discontinuation. This leads to aspirin failure or aspirin resistance. Another clinical issue, which the aspirin lead to irreversible platelet inhibition, definitely the bleeding risk, it will be high, even if you will use the higher dose, more than 100 milligram aspirin per day. All of us, we know the gastrotoxicity of aspirin. Dual antiplatelet therapy, it's indicated in all guidelines for any patient who presented by acute coronary syndrome. And we have 4 B2Y12 inhibitor, one which is old, the ticlopidine, no more ticlopidine now in the market, but we have now 3 B2Y12 inhibitor, which is ticagrelor, prasugrel, and clopidogrel. And here I want to concentrate about the ticagrelor, less affected by genetic polymorphism and drug-drug interaction. Platelet inhibition, the maximum, you can get 80 to 90% platelet inhibition by using TIGA if you compare it with prasugrel or clopidogrel. And the time of onset of action it's starting from 1 to 2 hours. And one of the most important advantage of using ticagrelor in patients with acute coronary syndrome, it's reversible antiplatelet inhibition. This is very nice recommendation from the recent European Society of Cardiology guideline about the P2Y12 inhibitor selection and timing. And you can appreciate here the level of evidence and the class of indication, or class 1 indication and level of evidence B. First one, in patient who with acute coronary syndrome, ticagrelor 100 milligram loading dose followed by 90 milligram twice a day on top of aspirin is recommended, regardless of the initial treatment strategy, including a patient pre-treated with clopidogrel, which should be discontinued when tiga is commenced, unless there is contraindication for ticagrelor. This is class 1 indication, level of evidence B. In patient with acute coronary syndrome undergoing BCI, I mean clear coronary anatomy to do angioplasty, like patient with STEMI, because STEMI you will open the infarcted related artery, and in non-STEMI patient, if the anatomy is clear. In this case, you can use prasugrel, and the dose 60 milligram loading dose with maintenance 10 milligram. But here, the anatomy should be clear. This patient, he will put stent, because if you will give prasugrel, you will have the chance to increase bleeding. And if the angio showed multi-vessel disease and the patient need CABG, you will postpone the CABG 7 days until complete elimination of the effect of prasugrel. What about the pre-treatment? Pre-treatment with P2Y12 inhibitor is generally recommended in patients in whom coronary anatomy is known, and the decision to proceed for PCI is made, as well as patient with STEMI. So pre-treatment should be given, I mean, patient presented in the ER with STEMI. STEMI, we will open the infarcted related artery. Here, you have to start the pre-treatment. But in high-risk non-STEMI, it's better to initiate the P2Y12 inhibitor in the CAS lab after angiography. Because if the patient needs CABG, so you will send the patient immediately for coronary artery bypass surgery second day, or immediately at the same day if there is high-risk feature, without delaying waiting the complete elimination of the effect of P2Y12. And this is class 1 indication, level of evidence A. So how can we know the ischemic risk and bleeding risk or duration of antiplatelet therapy? So we can use two risk calculator, Bersai's DAPT score and DAPT score. And we will use Bersai's DAPT score in the CAS lab, because if you want to keep the patient on short duration DAPT, I mean 3 months, so you have to know the bleeding risk of this patient. If high bleeding risk, use short DAPT. And if low bleeding risk, you have to use 12 months DAPT, okay? Because the bleeding risk low. But the only situation here to use short term DAPT 3 months if the bleeding risk high. DAPT score, you will use it if you want to extend the duration of antiplatelet therapy more than 12 months. So in Bersai's DAPT, if the score equal or more than 25, so this in case the patient have high bleeding risk, so you have to use short DAPT. And if the score less than 25, so the bleeding risk it will be low, so you will use a standard DAPT, 12 months indicated if the score, Bersai's DAPT score less than 25. This is very important slide to show the balance between ischemic risk and bleeding risk. In the first months of acute coronary syndrome, by all means, the ischemic risk exceeding the bleeding risk so far. So you have to use very potent and very intense antiplatelet agent in the first months of the acute coronary syndrome patient, whatsoever the bleeding risk, because the ischemic risk here exceeding the bleeding risk. After 1 month, so the bleeding risk, it will be the same as the thrombotic risk, so it's balanced. And the only situation to use less intensive antiplatelet therapy if the bleeding risk high. But if the bleeding risk equal ischemic risk, you have to continue the intense antiplatelet therapy for 12 months, like TIGA and aspirin for 12 months. And this is a diagram showed in first month, there is no role for less intense B2Y12 inhibitor, I mean the clopidogrel. The role here for more intense B2Y12 inhibitor, which is ticagrelor or prasugrel. And after 1 month, you will estimate the bleeding risk and ischemic risk. If the patient bleeding risk low or even equal to ischemic risk, continue intense antiplatelet therapy for 12 months. And the only situation to switch from more intense to less intense B2Y12 inhibitor if the bleeding risk is high, because it's not accepted to give a strong B2Y12 inhibitor in patient with high bleeding risk. This is a summary for expert consensus recommendation for switching from clopidogrel to prasugrel, or from TIGA to clopidogrel, or from prasugrel to clopidogrel. And this is a consensus definition. Escalation, it means switching from less intense to more intense oral B2Y12 inhibitor. For example, if the patient on clopidogrel, if you want to switch from clopidogrel to prasugrel or ticagrelor, so this is escalation therapy. De-escalation, switching from more intense to less intense B2Y12 inhibitor, from prasugrel or TIGA to clopidogrel. A change, switching from more intense to more intense, I mean from prasugrel to TIGA or from TIGA to prasugrel. Also, this is the consensus definition of timing of switch, acute, early, late, or very late. If you want to switch in acute stage, so this is switching in less than 24 hours. Early, switching from 1 day to 30 days during the first month. Late, if you want to switch after 30 days, but less than 1 year. Very late, if you will switch after 1 year from therapy. So there is 4 B2Y12 inhibitor available: clopidogrel, prasugrel, TIGA, and no more now ticlopidin. And the most available two B2Y12 inhibitor in our area, which is ticagrelor and clopidogrel. And today I will give very nice data about the comparison between the ticagrelor versus clopidogrel in high-risk non-SCT segment elevation MI. And this is 10 years outcome now from PLATO trial. And you know, the PLATO was published in New England Journal of Medicine in 2009. And this is head-to-head trial between clopidogrel and ticagrelor in patients who have high-risk non-SCT segment elevation MI. And you can see the two-arm clopidogrel arm and TIGA arm. And here the primary endpoint, which is cardiovascular death, myocardial infarction or stroke, and primary safety endpoint, which is total major bleeding. Here you can see the difference. The ticagrelor showed significant reduction of composite of cardiovascular death, myocardial infarction, or stroke if you compare it with clopidogrel, and this is about 16% relative risk reduction for this combined endpoint with significant p-value. And you can appreciate here the p-value 0.0003. This is highly statistical significant difference in favor of ticagrelor over the clopidogrel in patients who presented by non-SCT segment elevation MI. Not only the composite endpoint, the stentis thrombosis, and as you know, if any patient who did a stent and who developed stentis thrombosis, this stentis thrombosis can lead to acute MI and sudden cardiac death. For patients who are treated by ticagrelor, there is significant reduction of definite stentis thrombosis with significant p-value 0.009, significant reduction of definite or probable stentis thrombosis, and all kinds of stentis thrombosis decreased significantly in patients who are treated by ticagrelor if you compare it with clopidogrel. One of the most important findings here, the all-cause deaths significantly reduced in patients who are treated by ticagrelor if you compare it with clopidogrel. On the other hand, because the tiga, it's a potent medication with about 80 to 90% platelet inhibition, definitely you can see some bleeding difference in patients who are treated by tiga, and it's a little bit higher in patients who are treated by tiga, but in non-cabbage related bleeding. But in cabbage-related bleeding, there is no any significant difference between the two arms. What are the impact of Plato trial? Yes, there is positive impact for the Plato trial. Plato trial, it changed the guideline. Tiga is preferred in acute coronary syndrome patient over the clopidogrel. Registry data showed that use of tiga has increased drastically. And the most important question here, inquiry here, for patients who are treated by ticagrelor, definitely you have to keep the patient on the lowest effective dose of aspirin, because if you will use higher dose of aspirin, the bleeding, it will be increased. I will talk about a very, very hot topic during this time, which is cardiac injury in COVID-19. You know, the COVID-19 now, over the last months, all of us, we are at home. And the most responsible organism, it's a virus, and this is coronavirus. And you can see here on the right side of the screen, the structure of the coronavirus. You can appreciate here, it's locked crown, and you can see the spikes here. There is 4 proteins on the arising from the wall, which is a spike protein or S protein, and there is M protein, and there is E protein, and there is protein encapsulating the messenger RNA. And in the middle, you see the helical structure here, which is the RNA of the virus, and the red one, which is the lipid layer protecting the virus. This lipid layer, it's a very weak layer, and this is why the recommendation to wash your hand by hot water and soap, it can destruct this lipid layer and it can kill this virus. So this is the virus, and I will mention 2 real cases, and these 2 cases was presented to Mount Sinai Hospital in New York. The first case, 77 years old male patient last week, presented to Mount Sinai, and by generalized malaise, vomiting, diarrhea, productive cough, yellow sputum, and intermittent chest pain. Well-known coronary artery disease, but the coronary angio done for him before showed non-obstructive lesion in his coronary artery. During the presentation to Mount Sinai Hospital, his vital sign, okay, temperature normal, 36.7, blood pressure 118/85, heart rate 70, and respiratory rate 18, and SpO2 auto saturation 97%. Unremarkable physical examination. This is his ECG on the presentation to the ER to Mount Sinai Hospital, and you can appreciate here there is T-wave inversion in lead 3 and AVF with mild takeoff of the ST in V1 with hyperacute T-wave. This is his real X-ray. Upon presentation to the emergency department, you can appreciate the veiling and the multiple opacity all over the lung fields, left and right lung fields, indicating active pneumonia. 2 hours later, the patient collapsed with this kind of arrhythmias. This is atrial flutter, and the patient developed severe hypotension, respiratory distress, and he cannot tolerate the room air or even non-invasive ventilation. So the emergency doctor in Mount Sinai Hospital decided to intubate this patient and to put on vasopressor and they give intravenous amiodarone to revert this supraventricular arrhythmias. And fortunately enough, by using amiodarone, this kind of arrhythmia terminated and the hemodynamic of this patient improved. This is his lab test, classic lab test indicating viral infection, which is lymphopenia and neutrophilia. Plasma D-dimer significantly elevated, fibrinogen elevated, and ferritin elevated, metabolic acidosis in VBG, and the cardiac enzymes here, troponin, you can see the first set 0.15, which is elevated, then 0.13, then 0.11, and you can see there is the delta changes toward the decreasing cardiac enzymes. And the swab was done for PCR and came positive for COVID-19 positive test. This patient was treated as a COVID-19, and they are using hydroxychloroquine plus antibiotics and Sysromax. This is a combination now for treatment of COVID-19 at Mount Sinai and a lot of hospitals in the state, mainly in New York. Fortunately enough, this patient was significantly improved after initiation of this combination of hydroxychloroquine and Sysromax and antibiotics, and after intubation and vasopressor support. Second case, also 78 years old, hypertensive, smoker, but all known to have cancer prostate. But he was presented to the ER by stable hemodynamics. His main complaint, shortness of breath, no fever, no tachycardia, no hypertension, no hypotension, and all physical findings are okay. And this is his ECG. You can appreciate here in lead 1 and AVL, there is mild ST segment elevation in lead 1 and AVL. X-ray again showed the same finding of the previous patient, and indicating multiple obesity bilateral, taking the base, mid, and mainly base and mid in both lung field, suggesting bilateral pneumonia. Second, the ECG after 6 hours showed significant ST segment elevation, mainly in V2, V3, V4, and V5. Cardiac enzymes showed significant elevation of CK-MB and troponin, with elevation of D-dimer and proBNP also significantly elevated, and it was clear COVID-19 positive patient. This patient was treated by clopidogrel, aspirin, unfractionated heparin, and chloroquine with Sysromax, significantly improved after initiation of medical treatment. So what are the cardiac injury in COVID-19 infection? This is a definition of myocardial injury, defined as elevation of cardiac enzymes level above the 99 percentile assay, relatively common in COVID-19 infection, observed in 10 to 30% of all hospitalized patients, and the incidence increased in patients who admitted to the ICU. 22% of the patients presented by COVID-19, they have significant elevation of cardiac enzymes. So many have unknown cardiovascular disease in published series, but the two patterns here, there is two patterns, which is type 2 MI and type 1 MI. In type 2 MI, there is significant elevation of cardiac biomarker, significant elevation of inflammatory marker, significant elevation of the the X-ray finding and CT finding indication. The main problem here, it's infection and pneumonia. And the second problem, elevation of cardiac enzyme. So this is a definition of type 2 MI. I mean, the MI or myocardial injury, it is related to the pneumonia, not related to primary coronary artery disease. But if the predominant cardiac presentation, I mean typical pain with elevation of ECG, with elevation of cardiac enzymes, and the inflammatory marker even decreasing or normalized, so this is type 1 MI. And this is a mechanism of cardiac injury on COVID-19. If you look for the COVID-19 virus, so there is systemic inflammatory response associated with release of cytokine storm with immune dysregulation. This leads to cytokine-induced acute cardiac injury, direct acute cardiac injury, or lead to atherosclerotic plaque rupture in the coronary, which lead to coronary ischemia and acute cardiac injury. Second, the mechanism, which is oxygen supply demand, the classic type 2 MI due to hypoxemia and increased myocardial damage. Third, all of us, we know the mechanism of entry of COVID-19 to the body. You know, the S protein or spike protein, it is attached to ACE2 receptor, and ACE2 receptor not only present in the alveoli, it's present in the alveoli, in the lung, in the liver, in the kidney, and in the gut. So this enzyme, this virus attached to ACE2 receptor in the heart, which lead to myocardial, direct myocardial injury and lead to acute cardiac injury. The last mechanism, which is microvascular damage due to elevation of fibrinogen, plasma D-dimer, which increase the hypercoagulation state, which lead to coronary artery thrombosis and acute cardiac injury. Systemic inflammation and cardiac dysfunction lead to cardiac apoptosis and cardiac apoptosis of the myocyte, lead to systolic dysfunction, diastolic dysfunction. And this is a mechanism of direct myocardial injury mentioned before. This is a SARS virus, which is COVID virus attached to ACE2 receptor, which is located in the myocyte. Then it will invade directly the myocardium, lead to a direct myocardial toxicity and dysfunction. This is very nice histopathological changes in COVID-19 patient, and this is post-mortem biopsy from the lung, from the liver, and from the heart, and you can appreciate here the interstitial mononuclear inflammatory infiltrate in the lung, either in the left or right lung or liver, but the heart, it's less affected by this mononuclear inflammation. It's mainly involving lung. This is why the majority of this patient, they develop the other respiratory distress syndrome. This is very catastrophic complication from COVID-19. This is real case, just published 2 days ago, and patient presented by COVID-19 developed the myocardial injury, elevation of cardiac enzymes, elevation of ProBNP, elevation of D-dimer, and the most critical finding here, this patient was collapsed in cardiogenic shock, intubated, and he was kept on ECMO and the vasopressor. Cardiac MRI done for this patient showed preserved myocardial thickness with gadolinium enhancement in all myocardial segment, indicating myocarditis associated with COVID-19. For patients who presented by COVID-19 with cardiac injury, carry the bad prognosis and high mortality rate. But if the patient with COVID-19 presented without cardiac injury, so the mortality rate, it will be very low. It will be at least 0.2 to 0.4%. But once myocardial injury happen, the mortality rate, it will be very high. See, this is why in this group of patients, you have to do cardiac enzymes and ProBNP. This is very nice data for patients who presented by COVID-19 and who developed ventricular tachycardia, ventricular fibrillation, and sudden cardiac death. And you can see here in patients with COVID-19 positive, with troponin positive, the highest mortality rate, and the lowest curve, negative COVID-19 and negative troponin, very, very low mortality rate. So what are the recommendations for management in a specific patient who presented by COVID-19 and cardiac injury? Definitely clinical assessment, it's very important from cardiologists, ECG, echocardiography, you can do CT coronary angiography, and the CT or conventional coronary angiography. As regard the treatment, if patient who presented by COVID-19 and SCT segment elevation MI, so there is two management strategy. Some countries, they are preferred to give lytic therapy until to get negative PCR for COVID-19, then you can do intervention. But actually, it was failed in China because this patient, the patency from lytic therapy around 50%. So the gold standard now to send the patient to the cath lab and to give potent antiplatelet therapy, ticagrelor is recommended, and to send the patient to the cath lab and to open the infarcted related artery. Thank you so much for your attendance and to be with us, and kindly stay strong during this time. Thank you so much.
Thank you, Dr. Abdel Masoud, for this wonderful and comprehensive presentation. Actually, we have lots of questions from the online attendees, and we will answer their questions at the Q&A session. And now I would like to welcome Dr. Abdel Awel Mansari to start his presentation regarding lipid management in diabetic patients. Dr. Abdel Awel, you are muted. Can you please unlock the mute? It's clear now, Prof. We can see the screen. If you can make it full screen and start.
Okay, so you can hear me or not?
Yeah, we can hear you clearly, Prof.
Okay. Bismillah ar-Rahman ar-Rahim. First of all, thank you very much for joining us. Thanks for AstraZeneca. And I know this is not the right time actually for, of course, gathering activity. So at least we can manage through this participation. Anyway, what I will talk about is lipid management in diabetic patient. And just to go back a little through the history, in 1938, in Journal of Internal Medicine, there was the first relation which was discovered between high cholesterol and cardiac disease or angina pectoris at that time. Nearly about 50 years after the word hamburger appeared in English language. Anyway, when we are talking about diabetic dyslipidemia, of course, we need to answer one question: why diabetics? And then, of course, we will go through the management, and at the end, we will see some practical cases. So the first question to ask is, why diabetics in particular? If we remember Mr. Fett's study, which was a follow-up of nearly 347,000 patients for 12 years, that study showed many things, but it showed very importantly there was increase of cardiac death with each increase in cholesterol level. So if you see here, the cholesterol level here about 5 to 5.4, which is about 200, you usually multiply by 38, or to make it simple, by 40 in non-diabetic. The mortality will be, of course, higher than less than 4.5 and lower than less than 6. So this was really very important. With each increase in cholesterol, there was increase in mortality. That was in non-diabetic and was in diabetic also. Again, with each increase in cholesterol, there is increase in death. But it was very noticeable that at any given point, the risk of death in diabetic was about 4 times compared to non-diabetic with each level of cholesterol. So diabetes alone is considered a risk for coronary artery disease death. This was not the only study, but there are many others, like this one in Framingham study, which showed after 20 years of newly diagnosed diabetic, the risk of mortality was double in men compared to non-diabetic men, 17 versus 8, and 4 times in women compared to non-diabetic women, again 17 versus 4, which means actually diabetes eliminates the protective factor of being pre-menopausal. In Nurses' Health Study in women, it showed that after 15 years of diabetes, the risk of death in diabetic equals to previous coronary artery disease patient. And this was also which was translated into the statement that the first heart attack in diabetic patients has a mortality equals to the second heart attack in diabetic patient. And of course, much worse if there was over 15 years diabetes and previous coronary artery disease, in which the risk of death was about 30%, or nearly 1 in every 3. So the main thing to do here is to prevent rather than waiting for treatment. So diabetic dyslipidemia is basically, as you can see here, high cholesterol or nearly high cholesterol. Triglyceride mainly is high, HDL is slightly low, while LDL is normal, as you can see here, 119. So it's basically 3 triads: high triglyceride, low HDL, and normal LDL cholesterol. So why normal LDL and high mortality? As you can see here, at any given space, if in the normal subject, the LDL particles are large, okay, and they contain ApoB, which is in red. ApoB, of course, is the atherogenic part of the LDL. And when you have small, dense particles, like in diabetic patients or smokers, then you will have very large ApoB compared to the space, which means higher risk. So a small, dense LDL, which is more atherogenic, is in diabetic patients compared to non-diabetic. In addition to all other factors, in diabetic patients, you have hyperglycemia, you have platelet activation problem, you have constrictor remodeling, you have, of course, the inflammatory gene and nitric oxide release problem. So you have many other factors which can cause coronary artery disease death. So the question here is what to do at this point. And of course, what we need to do is to prevent, as we said earlier, rather than to wait for the event and then start treatment. The first line in prevention and or on management is healthy lifestyle. And we know that with healthy lifestyle, there is very much improvement. And according to the American Diabetic Association guidelines of 2020, the lifestyle which are recommended are the Mediterranean diet and DASH diet, in addition to the physical activity. So lifestyle is not only diet, it's diet, activity, stop smoking, and of course, stress management. There are many things. But if we just go through Mediterranean diet and DASH, which is dietary approach to stop hypertension, there is very good improvement, as we will see later, and also in physical activity. Now, if we go just a little through the fat and the fat in diet, we need to remember that fat is something which is actually covers many things: triglycerides, cholesterol, everything. So when we are talking about fat, it's different. It's than cholesterol. It contains cholesterol, but it's not all, okay? So when we say saturated fat, usually it comes from the animal. So there is no fat or saturated fat. It should be less than 10% of the total calories of all our day. And if you see here, the saturated fat like milk, like cheese or butter, it shouldn't be much, though there are some people that will say that it's not harmful. Actually, it's harmful, and it should be minimized to less than 10% of our total calories per day. So why some people say it's not harmful? Because they compare it to trans fat. Yes, and actually trans fat or hydrogenated or partially hydrogenated fat, it's the worst fat of all, and it shouldn't be consumed at all. Actually, the European Society of Cardiology states that it should be zero. Avoiding any consumption of trans fat is the key measure of the dietary prevention of cardiovascular disease. while the American Diabetic Association limits it to 2 grams a day. When we say 2 grams a day, we need to remember that something like this, donuts already has 5 grams, which is more than the double of the limited amount. Now, fortunately enough, in Saudi Arabia, the Saudi FDA prevented partially hydrogenated oil in the food industry and gives a period of the manufacturer to comply, which started in 2020, which is really very good news because it's really, directly associated with cardiovascular disease. Now, that was the bad fat. What about the good fat or the good diets? The best, as we said earlier, is Mediterranean diet. And this Mediterranean diet, of course, includes a diet with monounsaturated and polyunsaturated. And if we say here about the different oils, we need to remember that the Mediterranean diet has, of course, fish, nuts, some dairy products, in addition to fruits and vegetables, and oils, not butter. Oil, there are different forms of oils, but we need to remember all these commercials. There is no cholesterol in the oil. Cholesterol comes only in the animal cells. It doesn't come in the plant. So what's different in different forms of oil is the saturation of the fatty acids. If it's very saturated or saturated fatty acid, this is bad. This is something like palm oil or coconut oil. While if it has poly and monounsaturated, that's much better quality, like olive oil, canola oil, sesame oil, and sunflower oil. Exercise also is really very important, but the catch with exercise, it needs to be always, it needs to be a part of our life 3 times a week, 4 times a week. 150 minutes a week is enough. Of course, more is better, but anyway, it should continue. After that, of course, medications, and the most important medication is statin. And if we go through statin, we need to go back to CARTS study, which is one of the most important studies in the history of diabetic patients, because CARTS study showed after they included about 2,800 patients, diabetic between 40 to 75 years with no coronary artery disease, they are but high risk. Their LDL cholesterol was normal. As you can see, LDL cholesterol was 118, 119. And this study was supposed to go for 5 years, but it was terminated after 3 years only because the mortality was much less, about 22% in the statin group compared to non-statin group. And since then, the recommendation came, what we'll see. But also this was seen in Jupiter study. Jupiter study, actually, it was, again, very large study, which is about 18,000 patients. And these also had normal LDL cholesterol, and they were started on rosuvastatin or Crestor, and there was a reduction of 50% of LDL. Anyway, again, the trial was stopped after a median follow-up of 1.9 years because of the benefit of cardiac risk reduction. Now, the recommendation states start statin in all diabetic patients over 40 years, regardless the LDL cholesterol. And if you see here, for patients with diabetes age 40 to 75, then use moderate intensity statin. These are just diabetic over 40 years without other risk factors. We can use moderate intensity statin. While in this group, which is multiple atherosclerotic risk factors, then we can start right away high intensity statin. Let's see practically what is moderate intensity and high intensity. Now, the high intensity statin, we have only 2, which is atorvastatin, 40 to 80 milligram, or rosuvastatin 20 to 40 milligram. While other moderate intensity, atorva 10 to 20, rosuva 5 to 10, Simva 20 to 40. And this is really very important because there are many patients with diabetes and on simvastatin 10 milligram, which does not have any scientific support. Now, if you see the differences between the atorvastatin and the rosuvastatin or Crestor, you can see the reduction of LDL cholesterol is minus 51 in 10 milligram compared to minus 39 in atorvastatin, while after 12 weeks, again, the 20 milligram showed minus 57 compared to 20 milligram atorvastatin minus 46, which indicates, I mean, very simply that the 10 milligram of rosuvastatin or Crestor will give you similar results of 20 milligram of atorvastatin. Now, there is another benefit for the maximum intensity statin, which is reduction of the triglyceride. As you can see here from the base study, that the reduction of triglyceride with atorvastatin 80 milligram, which is actually not used, 54% reduction, and 40 milligram is 44% reduction. Rosuvastatin also in 40 milligram, 48% reduction, and 38% reduction in 20 milligram. And this is really very important to remember because we had many patients with high triglyceride, which is higher than 150, but lower than 400. And again, in these patients, still the statin or strong statin will be the first choice to decrease the LDL, decrease the cardiac mortality, and also decrease the triglyceride in these patients. So what about if you don't reach the target with statin? At that time, the recommendation again, to add ezetimibe to maximally tolerated statin so you can reach 50% reduction. Now, ezetimibe will decrease the absorption of the cholesterol by inhibiting NBC1L1 receptors. And from different studies, we can show that, there is a reduction of LDL cholesterol with combination with ezetimibe, statin with ezetimibe, more than with doubling the statin dose. As you can see here, with simvastatin 40 milligram, there was a reduction of LDL, and addition of ezetimibe, there was more reduction, and also there was cardiac benefit by which is 6.4% reduction, which is small, but it's also significant. Now, if there is no, we didn't reach the target with both medications, the last one is BCSK9 inhibitor, which is very strong, but also its injection, it's very expensive, and we don't have enough data to support the use before statin. We need to remember that the BCSK9 inhibitor data was on these patients who were already on statin. So what is BCSK9 inhibitor? This is really very nice slide. You can see there are many LDL receptors, which are the red ones here. The LDL with the B100 will attach to the LDL receptor, which is internalized into the cell. And in the cell, in the endosome, there will be destruction of the LDL, and the LDL receptor will go back to the surface. All right. Now, in case of BCSK9, you have here BCSK9, as you can see here, which will attach to the receptors like this. So the whole process will start right, but it will finish that way. It will not finish that way. So the LDL receptor will attach to the LDL, and then it will go inside, but the LDL receptor will be destroyed inside instead of going out. So there will be much less LDL receptors, which means that if we have high BCSK9, we will have less LDL receptors, and then of course we have high LDL. While if we inhibit the PCSK9, we will have more LDL receptors and low LDL. Now, this is a study, of course, which showed that in evocolumab or Repatha or PCSK9, there was a reduction, about 60% reduction of LDL, and also 15% reduction of cardiac events here, and cardiac vascular death, myocardial infarction or stroke by 20%, the secondary endpoints. So we have very good reduction, and you need to remember this reduction in addition to the reduction which was already given by statin. Somebody will ask about HDL and high triglyceride, which I'm not going to talk about for one reason, because there is no study which showed that improvement of HDL or a reduction of triglyceride, which significantly will significantly decrease the cardiac mortality. This is AIM-HIGH study, which you can see here, niacin, which will decrease the triglyceride and improve the HDL. In patients with LDL already below 70 and on statin, then niacin was added. There was reduction of triglyceride and there was increase in HDL, but the mortality actually did not profit here. So we need to remember that when we talk about cardiac disease in diabetic patients, it's always the priority is LDL cholesterol, and LDL cholesterol. We usually start with lifestyle modification, then statin, ezetimibe, PCSK9 inhibitor. And believe it or not, all this was only an introduction, and now we will go to our subject. Okay, let's see this case. This is a 33-year-old male with no significant past medical history. He's not a smoker. He's concerned about LDL cholesterol of 143. What do you do in here? Let's see another case before we answer. This is 58. This is not 31. This is 58. And he's a smoker, 10 cigarettes per day, and LDL cholesterol of 155. What I'd like to show in these two cases, we have different patients. Always you need to assess the patient risk. So with age of older than 45 male or 55 female, this is the risk factor. The family history of premature coronary artery disease is another risk factor. Smoking, hypertension, low HDL, all are considered risk factors. So actually when you see these three, these are completely different. Even if they have the same LDL, only what you need to do is to go back to assessment of specific patients and for requirement of different medications. But actually in diabetic patients, we don't need assessment, as we said earlier, because the diabetes mellitus should be treated like any established coronary artery disease. Now, this is a heart risk calculator from the internet. You can get it, it's okay. You can calculate for any patients. So this is 55-year-old male, and his HDL is 44, total cholesterol is 230, his hypertensive, slightly hypertensive, and he's not diabetic, not smoker. The 10-year risk for heart disease or stroke was 8.5%. So let's see the same patient if he is a smoker now. Again, the 10-year risk of heart disease, this is for the same patient, is 18% compared to 8%. Now, if he's a smoker and diabetic, then the risk will go up to 32%. So these will tell us that there are many risk factors for coronary artery disease, but smoking and diabetes are really, really very strong determinant for heart disease and stroke. But we need also to remember that diabetic patients are not equal. Why? Because diabetic patients with target organ damage is higher risk than the patients without target organ damage, which is nephropathy, retinopathy, and neuropathy. The patient with dyslipidemia, patient with hypertension, with abdominal obesity, and non-alcoholic fatty liver disease. And this is from, again, from European Society of Cardiology 2019. This is from European Society of Cardiology 2019, which show you different targets for diabetic patients. Actually, this is the first patient, young patient, diabetic with no other risk factors, and he has diabetes less than 10 years. So the LDL target should be less than 100 or 2.6 millimole per liter. If the patient is already more than 10 years or other additional risk factors without without organ target organ damage, here the target will go down to 70, while if there is target organ damage or other risk factors, the target should be less than 55. So the LDL cholesterol should go lower and lower with increasing the risk. More than 10 years, other risk factors, target organ damage, and all these, of course, will be very strong indicators for mortality from coronary artery disease. And this what was seen also by American Association of Clinical Endocrinology, nearly the same. So just to summarize these two slides, LDL targets in diabetic patients, all diabetic patients should be with LDL less than 100. Other risk factors like more than 10 years, the LDL target should be less than 70. If the patient had established coronary artery disease, end organ damage, or 3 risk factors, then the LDL target will be less than 55. Now let's move to something which is completely different, which is some clinical cases. And let's see this first case. Now you have this 45-year-old male, diabetic type 2 with no coronary artery disease, and LDL is 121. Of course, we will use lifestyle modification, but will you consider medical treatment or not? And the answer is yes, we need to start statin. Now, if he had 45-year-old male, diabetes type 2, and LDL 96, you will consider treatment? Yes, we need to start statin. And even if the LDL cholesterol is 65 in 55-year-old male diabetic, again, we need to start statin. And according to the recommendation of American Diabetic Association, even if the patient had LDL less than 30, he's diabetic and over 40 years, he needs to be started on statin. And somebody will ask, but the LDL cholesterol is low. Statin is not for the LDL cholesterol. Statin, you remember the previous studies, Jupiter and CARS, decrease the mortality even with normal LDL cholesterol. In all new studies, again, with the PCSK9, showed even very low LDL was not actually associated with increased mortality. Now, this is the very strong statement of different recommendations. One of them is American Diabetic Association 2020, start statin in all diabetic patients over 40 years old. Now the question is, what about if somebody younger than 40 years? You can see our patient here, he started already on lifestyle modification and his LDL is high. Now the recommendation in diabetic patients younger than 40 years with LDL less than 100, there is no need to start anything. If it's more than 100, you will give 3 months for lifestyle modifications to reach LDL less than 100. If he didn't reach LDL less than 100, then we need to start statins. If you have a patient younger than 40 years with previous coronary artery disease, then of course the target will be LDL will be less than 55, and we need to start like this patient. But anyway, any previous coronary artery disease, whatever the age, you need to start statin. Now, if you have young patients, somebody will tell you he's younger than 40, but he doesn't have risk. Actually, before coming to this conclusion, we need to assess the patient by history and examination. And as you can see, this guy for the same LDL cholesterol is 65, and this is 65, and they are not, they are diabetic, but this patient is a smoker, hypertension, His young brother had coronary artery disease and retinopathy, while this patient is non-smoker and no other risk factors. So the statin is indicated very strongly and in this case to reach LDL below 100, while in this case you can just follow up every year till he reach the age of 40 years, and then you need to start a statin. Now, what about with somebody with coronary artery disease, diabetes? LDL is 159. Of course, we need to start a statin and to reach LDL target in coronary artery disease, which is less than 55. Now we'll start a statin. But what about the LDL target? The LDL target, we said earlier, if he didn't reach, then this is like this patient. He was started on atorvastatin 40 milligram. It went down the LDL from 159 to 121. So what do you need to do in this case? And this is a real case for one reason we need to remember. We assume always the patient takes the medicine. So if the target not reached, increase the dose. We might increase the dose or shift to stronger statin or add ezetimibe, right? But also you might ask about compliance. Did the patient actually take the medications within the last 2 weeks or 3 weeks? He used to miss some days of the week. So let's see if we increase the dose of atorvastatin. He's here, right? 40 milligram. So if we go up from 40 milligram to 80 milligram, then we have additional 3% reduction of LDL cholesterol. And this goes actually with all statin. When you start a statin, you will have the very good reduction of the LDL cholesterol, while when you double the dose, you will have 6% additional reduction of the LDL cholesterol. So increasing the dose will not be the choice, and shifting to another statin in this medicine will not be the choice. As you can see here, you will add ezetimibe, and in this case, it's supposed to go 27% additional reduction with ezetimibe compared to 11% LDL reduction if we increase the dose, according to this study, okay? Now, what happened actually, that with ezetimibe, the LDL cholesterol went down from 121 to 96, which is very good reduction, but again, we did not reach the target. The target we said is LDL below 55, or you can sometimes consider 50% reduction if it's easy. So in this case, if we didn't reach the target with statin and ezetimibe, we add PCSK9 inhibitor. And after PCSK9 inhibitor, it went down to 51, which is again below 55. So we reached our target. So the practical question, when to use PCSK9 inhibitor? Of course, in case of familial hypercholesterolemia, we start, this patient actually was in 2013, as you can see, before the availability of PCSK9. The patient was on statin and ezetimibe, and LDL was 855, which is of course very high. The patient was sent to electrophoresis and he did plasmapheresis, and he never comes back actually. But this, our patient with familial hypercholesterolemia, I saw about a year ago, his LDL was 306, and we started statin and then ezetimibe, and then we added PCSK9, and it went down to 137, which is, as you can see, we said the target sometimes for the LDL reduction is 50% if you cannot go to 55 or something. So the target in higher number of LDL will be 50% reduction, and this was reached with LDL from 306 to 137. Another indication for the PCSK9 is the intolerance for statin. So if you want to use PCSK9, it should be on the top of statin, except if there is intolerance to statin. With each increase with medicine, you can see that high intensity statin like rosuvastatin 20 milligram, there was a reduction of 50% of LDL. And then if you add ezetimibe, you will have 15% additional. And so you might have, with all these combination, 85% reduction of LDL cholesterol. Now I will go through the summary of this presentation. We know that the diabetic patient is high risk for coronary artery disease. The mortality is early, and the best treatment in this case will be the prevention of coronary artery disease. Now, the first prevention would be lifestyle modification and the statin together, especially if over 40 years. And then if we didn't reach LDL target, we can add ezetimibe and PCSK9 inhibitor. We need to remember that statin should be started in all diabetic patients over 40 years of age. And then we add ezetimibe and PCSK9 inhibitor. And the statin is not only for the LDL or for the cholesterol, it's for the reduction of cardiac events, as different studies showed, like Jupiter and CARDS study. Now, if younger than 40 years, no risk of coronary artery disease, then we start lifestyle modifications. And if we didn't reach LDL below 100, we can start, of course, medications. This already was seen. With each increase of medicine, there is additional reduction of LDL. And thank you very much.
Thank you, Dr. Abdelkawi, for the wonderful and comprehensive presentation. Actually, it was a very rich one. We have lots of questions for you, Doctor. Also, we'll go through them during the Q&A session. And now I would like to welcome Dr. Ali Sultan to start his presentation. Dr. Ali, if you can share your presentation, please.
بسم الله الرحمن الرحيم الحمد لله وحده والصلاة والسلام على من لا نبي بعده سيدنا محمد وعلى آله وصحبه أجمعين. I'm very grateful to AstraZeneca to give us this opportunity on a virtual basis and see our colleagues, and hopefully we will be helpful and informative to our audience who have taken from their time on a Friday to join us. My talk today is about the cardiorenal risk in diabetic patients. But at the beginning, we will try to just link of our talk to our current situation and what is the relation between diabetic patient and the coronavirus from diabetic point of view. Type 2 diabetic patients are more susceptible to these kind of infection, and these infection, as any other infection, increase the insulin requirements and make the patients more prone to DKA. So we have to take an extra consideration for our diabetic patients and to make them more compliant with the basic instruction and to avoid this kind of infection. The impact in the cardiometabolic disease was covered very well by my colleague, Dr. Abdel Maqsood. But this is a very recent study in March from Wuhan, when there was 191 patients, 137 patients of them were discharged and 54 died in hospital. Among those admitted, the comorbidities in those patients, 30% were hypertensive, 19% of them were diabetic, and 8% of these patients are having coronary heart disease. This is to give you a view of how much these comorbidity can affect the patient's course with coronavirus, and hoping that we will not go to that stage and keep our patient as much as possible in the preventive stage, inshallah. So today we will talk briefly about the heart failure in the medical background, the declare updates, and the recommendation guidelines from the ACE and the European Society of Cardiology. But let's take a look first on the heart failure in diabetes. It is one of the most common cardiovascular complications of diabetes, and it is the most disabling and deadly complication of diabetes. Very high rate of subclinical heart failure and diastolic dysfunction in diabetic patients. This is a very important statement because these patients are asymptomatic and we should look for them and not wait until they have the symptoms of heart failure, and it might be too late at that stage. The effect of diabetic medication in such conditions are variable, and this is what we be looking at during this presentation. The heart failure in diabetic patients are being divided upon the preserved ejection fraction and reduced ejection fraction. When there is a concentric left ventricular failure, and mainly it is a diastolic dysfunction, the reserved left ventricular function, ejection fraction, should not be a barrier towards the diagnosis. And the usual heart failure with the systolic dysfunction and the reduced ejection fraction also can happen in diabetic patients, and both of them can increase the cardiovascular death and hospitalization in heart failure of diabetic patients. If we look at the prevalence of unknown heart failure with preserved ejection fraction and see the difference which is increasing with age, the heart failure with reserved ejection fraction percentage compared to the one with reduced ejection fraction. Above 80 years of age, 10% will be with reserved ejection fraction compared to reduced ejection fraction with the preserved one at 37%. So less than 1/3 of the patient will be coming with the classical symptom of heart failure as the patient become elder and elder. And in the younger group, between 60 and 64, only 2.8% compared to 13% of patients with heart failure among those two groups. The prevalence of the undiagnosed heart failure is high. In this group of more than 580 patients, there was no heart failure in 72 patients. They are all diabetic, but those who have heart failure, 23% of them having a heart failure with preserved ejection fraction, where only 5% of them were having heart failure with reduced ejection fraction. 28% of our type 2 diabetes went undiagnosed in this cohort. This also showing us that the second most common manifestation of cardiovascular complication after peripheral vascular disease is heart failure, and it is a deadly one. When we look at the duration of diabetes in those patients who were having no evidence of ischemia during a stress test baseline, the diastolic left ventricular dysfunction was shown in 16%, systolic dysfunction were 27%, and normal left ventricular function with 32%. So this gives us a message that the heart failure in diabetic patients who passed 5 years of duration of diabetes should be looked by us and not to wait until the patients have the symptoms and complain. So in 68% of the patients with type 2 diabetes have evidence of left ventricular dysfunction by 5 years of diagnosis. The relation between the heart and the kidney is well established since long time, and they are closely linked together. Early protection of the heart, kidney will affect and have impact on each other. And as being said, the diabetes affect the pump and the plumbing. Heart failure, major adverse cardiovascular events lead to mortality. And this is very clearly showing that the diabetes without heart failure, their proportion of survival, how smooth going through 5 years, and how much is decreased and reduced when the patient developed heart failure during the 5 years of this study. And the poor prognosis is very evident also in this study. If we see the patient of heart failure and hospitalization compared to heart failure without hospitalization, but the best ones when the patient has no hospitalization and no heart failure and he's only diabetic. So heart failure with hospitalization is worse than heart failure without hospitalization. So the core message of this introduction for the link between type 2 diabetes and heart failure is that diabetes leads to a malignant form of cardiovascular phenotype. And the key cardiovascular events in diabetes is macrovascular disease, microvascular disease, and heart failure. Both prevention and treatment of both preservation and treatment of both atherosclerotic events and heart failure are important to reduce cardiovascular death in diabetes, as the cardiovascular events always been mentioned and taken as atherosclerotic complication only. Heart failure should not be ignored in this matter, as it is a leading cause of death in our type 2 diabetic patient. So after this brief link between the type 2 diabetes and heart failure, we will go through the DECLARE study, TAMI 58. The design of this study showed that it is more than 17,000 patients, and it is a multinational randomized double-blind placebo-controlled, and it was part of the phase 3B cardiovascular outcome trial. The dapagliflozin 10 milligram in one arm, and the ratio was 1:1, and the placebo arm were combined. In both arms, all other glucose lowering agents are per treating physician. And the study was event-driven duration of more than 1,390 days. And the median follow-up was 4 years and 2 months. What was the primary safety endpoints? The composite cardiovascular death, non-fatal MI, non-fatal ischemic stroke, which we will be referring during this presentation as MACE. Primary efficacy outcome was MACE, composite of hospitalization for heart failure or cardiovascular death. Secondary endpoint was the renal composite endpoint, sustained more than 40% decrease or more than or equal to 40% decrease in ejection in the EGFR to EGFR less than 60, and or in the stage renal disease or renal or cardiovascular death and all-cause mortality. This is an important slide for the comparison of the population between the major cardiovascular study and the other group of the sodium glucose transporter inhibitor 2, where we would look to take a look on the very important aspect of these difference, that the multiple risk factor, ischemic heart disease, peripheral vascular disease, and cerebral vascular disease was 10%, and the established cardiovascular disease is 40% in the baseline study. In the DECLARE, the eGFR was 85%, where in the EMPA-REG was 74%. One of the strongest cardiovascular factor is the microalbuminuria, and it was present in 30% only, where it was 40% in others. So the patient in DECLARE trial had a better baseline renal function than the EMPA-REG outcome or the CANVAS outcome, which make this study make a more near to our daily patient we are seeing in our clinic. We are not seeing in endocrinology or in internal medicine or in family medicine a pure cardiac high-risk patients, or we are not in nephrology seeing an end-stage renal disease patient. So this is mostly our common pool of patients in our daily practice. So the primary endpoint in the composite heart failure or cardiovascular death was a reduction by 17% in the relative risk reduction, which make the p-value superiority reached with a hazard ratio of 0.83 in the DAPA 10 milligram arm with the 1,417 events only. When we look at the MACE primary endpoint, the non-inferiority p-value was reached, but the superiority was not reached with a hazard ratio of 0.93 only. And when we look in the largest population in the number of type 2 diabetic patients were low cardiovascular risk among the other studies done for cardiovascular risk in the group of SGLT2 inhibitors. Mostly 99% of the EMPA study were already with cardiovascular disease. In the CANVAS, 1/3 of those patients, sorry, 2/3 of those patients were having cardiovascular disease, and only 40% in the DECLARE study were having cardiovascular events. So the DECLARE demonstrated cardiovascular safety with dapagliflozin in this broad cardiovascular risk in type 2 diabetes population earlier in their cardiovascular risk continuum. And when we look at the renal, as we have mentioned earlier, less than 60 ml were only 7% of the population, and more than 90%, 48% were of the DECLARE population. Here specifically, we will look at the medical history in the DECLARE population. MI were only present in 20%, and the ischemic stroke were in 6.5%, where in the EMPA-REG, it was more than double this number in the MI history and 23% in the stroke history. The composite of heart failure or cardiovascular disease of individual composites were very much in favor of the heart failure and cardiovascular death, hospitalization for heart failure as well. And the reduction were 17% and 27% respectively. Also, the dapagliflozin prevents heart failure consistently across the board in the range of type 2 diabetes patient and history of cardiovascular disease and heart failure, by 38% with established cardiovascular disease, 22% hazard ratio in the heart failure with history of heart failure, and the patients with 10% of patients in the DECLARE had all history of heart failure only. When we go to subgroup analysis of the heart failure patients, we look at the population, we find that there was no non-heart failure in 88% of the population, and heart failure with reserved ejection fracture in 3.9%. So these are the subgroups of patients in the DECLARE, and this is their analysis. There was 38% reduction in the hazard ratio when there was heart failure with cardiovascular death, and the 36% reduction in heart failure and cardiovascular deaths were reduced as well in 13%. The subgroup for MI patient, there was a reduction of 16% of the risk reduction, relative risk reduction in the MI subgroup outcome with those patients with prior MI. So with the patients with the higher risk, the benefits of the medication start to show more and more. Cardiovascular and renal benefits subgroups, when we take it for the MACE reduction, it was also 33% reduction. And with myocardial infarction in the double primary outcome with the renal and the cardiovascular death, there was 34% reduction as well. Ischemic stroke was reduced as well by 39%. The double primary outcome of their composite component with dapagliflozin versus placebo with the duration. This is very obvious, but here the beauty that it was showing through the continuum of developing type 2 diabetes. It starts to show benefits and in favor of dapagliflozin with the patient who have history of diabetes even less than 5 years. But these benefits start to be more and more evident when we go higher and higher with the duration, especially with those who have more than 20 years duration, and it goes up to 40% with more than 20 years. And it also was evident as well in the other components. So these results shows that the effect of dapagliflozin are consistent no matter the duration of diabetes in terms of reducing the cardiovascular heart failure risk, but the treatment effect relative to MACE was significantly larger among patients with longer duration of diabetes. And this is well known to all cardiovascular studies. The secondary endpoints where we were looking at the renal outcome and the preservation of the eGFR, 24% relative risk reduction was shown in renal composite and heart failure. And this renal outcome, just to remind you, which was mentioned at the beginning, is that the 40% decrease in eGFR and the percentage of patients going to stage renal disease. And there was 47% reduction in renal composite endpoint without cardiovascular disease, and 24% relative risk reduction in renal composite endpoint with cardiovascular death. With all-cause mortality, there was no much differences. Let's look at the urinary albumin to creatinine ratio change outcome in the DECLARE. This is a well known slide. If I just take the name of the study and put the name of any other ERB or ACE component, will show this picture. People in the 80s and the 90s were very much worried at the decline at the beginning on the eGFR of the renal patient using those markers. Here, our sodium glucose transporter inhibitor showed the same picture. At the beginning, there is a transient reduction in the eGFR, but this beautifully preserved the eGFR in the dapagliflozin arm, where those patients who were having the placebo starting from year 2 decline and their renal function deteriorate more. Dapagliflozin increased the likelihood of patient improving in their albuminuria and changing patient from microalbuminuria to normal albuminuria, from microalbuminuria to normal or micro, and from macro to normal albuminuria as well. So when we look at the population of the DECLARE study, when we try to go to those patients who look like they're having no renal problem or no cardiovascular events, it was not significantly showing number. When we have it for atherosclerosis, but no prior MI, also it was not there. So this kind of population are difficult to show positive result in any study and need at least 20 years study to show positivity and longer duration. But when we just move to the prior MI group, we find a significant improvement, and the number need to treat in your 4 years was 39%, and 4 years even 53. And prior MI and less than 2 years was not that significant. So in summary, the primary composite output of hospitalization of heart failure for cardiovascular events were significantly reduced with dapagliflozin. Risk of heart failure hospitalization was reduced irrespective of history of heart failure, presence or absence of established atherosclerotic cardiovascular disease or ejection fraction. Fewer MACE events were observed in patients receiving DAPA than placebo. However, this did not reach statistical significance. A pre-specified subgroup of patients with pre-MI demonstrated a significant reduction in the MACE with dapagliflozin. Reduction in renal outcome in dapagliflozin group was observed with nominal significance. Fewer patients in dapagliflozin group than the placebo group reported serious adverse effect, 34% versus 36%. So let's take a quick look on the recommendation worldwide and how it was affected by the recent literature since 2013 and forward. The picture of the ADA recommendation has changed, and we are no more seeing the previous picture, and now the patients has been divided to high risk for heart failure or chronic kidney disease with predominates in them, or atherosclerotic cardiovascular disease predominate. And we can see after metformin for ADA and the lifestyle adjustment, the SGLT2 group become a priority in those heart failure patients, where atherosclerotic patients predominate. The GLP-1 became the first choice, regardless of the other groups. The ACE and the American College of Endocrinology recommendation in 2020 mentioned a similar issue after the lifestyle, regardless of the A1C, after monotherapy with metformin, the GLP-1 and the SGLT2 became the priority. independent of glycemic control if established atherosclerotic cardiovascular disease of high risk of chronic kidney disease, stage 3, or heart failure. The updated ACE and American Heart Association in March 2019 recommendation referenced the DECLARE as the reference for the studies for the guidelines in the primary prevention of cardiovascular disease. And in 2019, the European Society of Cardiology guidelines make this controversial recommendation of that before metformin in patients with atherosclerotic or high risk for atherosclerotic heart disease or multiple risk factor, SGLT2 inhibitors or GLP-1 can be as a monotherapy. Thank you.
Thank you very much, Dr. Ali, for this wonderful presentation. And actually, I would like to thank you again. I would like to thank Dr. Abdelawi and Dr. Abdul Masood for this wonderful and comprehensive presentation covering all the CVRM disease areas. And now we would like to start the question and answer. We have a good news that we are reaching about 400 HCPs attending this live event from all over the GCC countries, starting from Saudi and having other countries from GCCs. And we have received lots of questions. So Dr. Abdul Masood, are you with us? Dr. Abdelawi, I see Dr. Abdelawi is here now. Dr. Abdul Masood, if you can open your camera.
Are you hearing me?
We can hear you, Prof, but please open the camera. Yes.
Yes.
Now we can see you clearly. As I was telling you, professors, that we are having around 400 HCPs. This is a record number of HCPs attending this live webcast through all the GCC's countries. So I would like to start the Q&A sessions by one question for Dr. Abdul Masood. Dr. Abdul Masood, the question is, recently we have seen new data about the use of antiplatelet monotherapy in high risk post-PCI patients. What's your opinion about this approach, the monotherapy approach, and how it will be impacting the clinical practice in ACS management?
Okay, Assalamu alaikum again. Actually, the guideline recommending dual antiplatelet therapy for 1 year, 12 months after acute coronary syndrome patients, whatsoever the patient management strategy given to them, medical treatment, PCI, or coronary artery bypass. So here we are treating acute coronary syndrome patient, not treating any kind of stent or surgery or medical treatment. So once acute coronary syndrome, it's equal TAP, not SAP. The era of SAP started in 2018 in the European Society of Cardiology meeting, and there is one trial which is global leader trial. In global leader trial, they did trial designed to use that for 1 month, and this trial 3 arms. The first arm, which is aspirin with ticagrelor for 1 month. Then the rest of the duration of the trial, it will be TIGA only as ASAP. And the second arm, which is regular, 12 months DAPT, followed after 12 months to stop B2Y12 and to continue aspirin, like Plato trial. The second, which is clopidogrel with aspirin for 12 months as a DAPT, then you will discontinue the clopidogrel and to continue SAP. So the outcome of this trial came negative for monotherapy as a SAP, but there is very important message from global leader trial. There is a message toward this benefit for reduction of bleeding and the benefit in patients who are presented by acute coronary syndrome. So here, from global leader trial, there is two important messages. The first one, which is acute coronary syndrome patient, they can give benefit. And the second, the bleeding risk decreased significantly. And because this group of patients, it will be in SAP, I mean, single antiplatelet therapy in the form of P2Y12, which is ticagrelor, the main outcome came from significant reduction of bleeding, not ischemic event. This is a message from the global leader trial, which was published in the European Society of Cardiology meeting in 2018. The second trial, which is Twilight trial, and this just published in latest TCT 2019. And in this trial design, there is two arms. Arm from Twilight receiving the ticagrelor with aspirin for 3 months as a dual antiplatelet therapy. Then the rest of the trial, it will be on TIGA only as P2Y12 with discontinuation of aspirin. The other arm to continue dual antiplatelet therapy for 12 months, then you will discontinue the aspirin and discontinue the P2Y12 inhibitor and to continue aspirin alone. And the outcome of this trial showed significant improvement of all kinds of bleeding in patients who are treated by SAP after 3 months using P2Y12 TIGA versus the other arm. And the conclusion came significant reduction of PARC, all kind of bleeding, 3, 4, 5, and all kind of bleeding without any increase in the ischemic event. So this is the main idea to use SAP in patients with high bleeding risk. The Twilight and the global leader give signal for SAP can be effective in high bleeding risk, but it is documented by Twilight trial that SAP as a single P2Y12 inhibitor, it's a very important to decrease bleeding without any increase in the ischemic event. They tried to use to stop in one trial, I cannot remember the trial, to discontinue P2Y12 after 1 month and to continue aspirin, and this is totally failed. So the main trend now, if you want to use SAP as a single P2Y12 inhibitor, it is recommended to continue P2Y12 and to stop aspirin. And there is evidence also for stop DAPT trial using clopidogrel to support the benefit of P2Y12 as a monotherapy and to discontinue the aspirin. I hope I answered the question well.
Thank you, Dr. Abdel Masoud. Also, we have another question, Dr. Abdel Masoud, from Dr. Tazim from KSMC Hospital. He is asking about the time intervals for the first, second, and the third set of troponin during the diagnosis.
Yeah, this is an excellent question. Thank you, Dr. Tazim. This is very important question for any patient who presented by chest pain, either in the emergency department or in outpatient clinic. So there is 3 protocols, 1 hour protocol, 2 hours protocol, or 3 hours protocol. The time interval depend upon the presentation, the presentation of chest pain. As you know, Dr. Tazim, there is angina score. Now there is angina score 1, 2, 3. So if angina score 3, we will consider this patient very high risk angina. I mean, by angina score 3, typical resting anginal pain, central to the chest, radiating to the left shoulder, left arm, radiating to jaw, and decreased by nitrates and rest. So this is angina score 3. In this group of patients, actually, we will admit this patient to the hospital to see if there is any tissue loss or myocardial necrosis by cardiac biomarker and echocardiography. But in patient with angina score 1 or 2, if we did only one cardiac enzymes and it came negative with lowest detected level 4 or less, this is enough to send the patient home. But you have to send the patient to the outpatient clinic to do another investigation like echo stress modality, either stress ECG, MBI, dobutamine stress echo. And if there is recurrent pain with normal cardiac enzymes, it's advised now to do CT coronary angiography as outpatient to know the patient risk. So the time interval for cardiac enzymes depend upon the angina score. Angina score 3, definitely one set, it's enough. If negative, admit the patient. Angina score 1 or 2, it's enough to discharge the patient home on the first set of cardiac enzymes using high sensitivity troponin and should be at the lowest detected level. If little bit high, repeat the second set. If the second set of cardiac enzymes showed no significant delta chain, I mean no increase from the first set of cardiac enzymes, it's safely to admit to discharge the patient. But if the second set, even after 1 hour, showed 50% increase, if the high sensitivity troponin normal, we will consider this is positive and send the patient for admission. And if the second set showed no change with same level of elevation after 1 or 2 or 3 hours, safely you can discharge the patient home. So the message here, if there is any significant delta chain, it means first set of high sensitivity troponin normal, and the second set showed 50% or more increase, even if the lower than the upper limit of normal, admit the patient. We will consider this high risk elevation.
Thank you, Professor. Also, we have one more and last question for you, Dr. Abdelmasoud.
Yes.
Any evidence against stopping B2Y12 inhibitor after from 3 to 6 months and continue with aspirin in coronary heart disease patient post-stenting?
Yeah, actually, this is the era of monotherapy now. The era for monotherapy in patients who are treated by drug-coated stent or presented by non-ST segment elevation, MI or STEMI. So now there is era of monotherapy. The era of monotherapy started, as I mentioned before, by global leader, and it's documented by the Twilight trial. But there is recent trials which proved to document the short data. The message here, aspirin as a monotherapy, it's not indicated. B2Y12 inhibitor, it's indicated and supported by Twilight because the Twilight showed significant improvement. The global leader showed a signal for improvement in ACS patient. The short depth, it's indicated in any patient with high bleeding risk. I mean, short depth at 1 month or 3 months or 6 months. And there is a lot of trial supporting to use short depth duration, like senior trial using the Synergy stent versus bare metal stent. And by this strategy in patients who are treated by Synergy, by the way, it's third generation bioabsorbable polymer with cobalt chromium stent metal. And by using the Synergy with short depth, there is significant reduction of MACE and target lesion revascularization. Another trial supporting the short depth, which is EVOLVE trial. Short depth, I mean the dual antiplatelet therapy for 3 months, and the rest it will be single monotherapy, and also showed the same benefit, reduction of bleeding with reduction of target vessel revascularization. There is some ongoing trial, but this trial is studying the depth, short depth in different kind of stent. But really the message here, we are not treating the different kind of stent. We are treating the patient. So if you want to read the stent, you can use short tap. But if you want to treat the patient, so you have to be 100% compliant for the recommendation of all guideline, European and American guideline and Canadian guideline. All guideline is still not changing the duration of dual antiplatelet therapy for 12 months after drug-coated stent, except in high bleeding risk, 6 months it's enough for dual antiplatelet therapy.
Thank you, Doctor, very much. And now we have some questions for Dr. Abdelkawi. Dr. Abdelkawi, we have one question from UAE. They are asking about some diabetic patient said how my cholesterol LDL is normal and I want to stop the statin and keep on diet. How safe to stop statin and see for next 3 months?
والله هو لو صدق وكيب اون دايت ده كويس يعني بس كل واحد شايف نفسه اون دايت يعني. طيب على العموم okay, first of all the studies were done on statin for a long time and there was no discontinuation. And secondly, the LDL cholesterol, usually the effect of statin will be off since once you stop. Actually, there was one study in clinical cardiology, effect of withdrawal statin on C-reactive protein. After 3 days only of discontinuation of statin, there was increase in C-reactive protein. And there are different studies here, which are, for example, in European Heart Journal, there was increased discontinuation of statin in survival of first MI, actually associated with higher total mortality and biological rebound. And again, another study in current pharmaceutical design, the discontinuation, this is a meta-analysis, showed that there is increased mortality after discontinuation. So it's lifelong treatment. And we need to remind our patient that this is not because of the LDL cholesterol, it's because of the event reduction which was seen in different statin studies. The last point, yes, there are some people who stop the statin because of the muscle pain, and this is acceptable because sometimes it can't be bearable. So in these patients, you might use other medications like ezetimibe if the LDL is slightly high, or like the PCSK9 in these patients, as I showed in the presentation. But the statin is lifelong, and discontinuation exactly will bring back the patients to the severity of previously.
Thank you, Dr. Abdelkawi. And also we have another question mentioning that during your presentation, we have seen the importance of risk assessment of dyslipidemic patient to decide the target goals. So what is your recommended risk assessment tool or scoring system to be used for dyslipidemic patients to decide the right target for them?
Okay. Basically, there are different tools. You can just go to Google's and write ASVD or atherosclerotic vascular disease, but you can go also to the, sorry, just 1 minute. You can go to the Apple Store and just type ASCVD, and it's ready there. You can just add the numbers and you will have calculation. But again, we need to remember these calculations usually for non-diabetic. For diabetics, everybody should be on a statin, especially over 40. And if it's below 40, then we need to try lifestyle if it's more than 100 or start statin. Diabetic has really very high risk and they should be started very early.
Thank you, Professor. One more last question. It's coming from Abba here in Saudi Arabia. What about PCSK9 treatment alone in high-risk patients?
No enough study actually, but this is one reason. But the other reason is you cannot pay 1,800 riyal every month for 2 injections in the rest of your life. Okay, this is really very expensive medication, which is excellent in LDL reduction. It's very good medicine, but the data showed there is a reduction of cardiovascular disease on these patients on PCSK9 on statin already. So we don't have data without a statin, and it's not actually practical to have this medicine as a primary It can be a primary for some reasons, like for some people who cannot tolerate statin, or very high LDL, like familial hypercholesterolemia.
Thank you, Dr. Abdelawi, for your answers. And actually, we have some questions for Dr. Ali Sultan coming from the online audience. Dr. Ali, first question coming to you. As per the declared results and the other cardiovascular outcomes for SGLT2 members, can we say that dapagliflozin is the only one which can give positive data? And what is the ideal patient to profile from your point of view for dapagliflozin?
No, we cannot say so, but your patient and where is your patient among the cardiovascular risk factor? Is he atherosclerotic patient of origin to have cardiovascular events, or he is a heart failure? As of now, the only approved for the heart failure is the dapagliflozin. So if your patient is from this category and the characteristic of these study patients is similar to the character of your patient, yes, the DAPA will be number one.
Thank you, Dr. Ali. And also we have another questions coming from Oman. What is the mode of action behind the significant renal positive results? And what is the cutoff point to discontinue the medications in the renal impaired patients?
Oh, thank you for asking this question for my friend in Oman. It is really an important question. It's not yet fully understood how this class help the kidney, although when you logically think about it, that it is secreting the glucose through the kidney. But when they studied this phenomenon more, they discovered that blocking the glucose reabsorption helped the kidney by reducing its work and less oxygen consumption. And by this way, and by preventing the overwork of kidney by reabsorbing the glucose, the kidney will relax. Also the osmotic difference will play a role, and the improvement in the efferent and efferent blood pressure is another one. But totally, it's not known that the reason for the improvement can be said 100% from this reason or the other reason. The other part of your question, let's make it clear. The use of this class and the EGFR is not because of the side effect like other medication. When the renal function deteriorate, you expect more side effect of this medication. No, this class will be of great help with the excellent renal function. And with the reduction in the renal function, you will expect that the efficacy may be reduced, but there is no more toxicity can be seen. And the number and the cutoff is still remain according to your country. Here in Saudi Arabia, still the Saudi FDA take 45 ml as the cutoff point, although the recent study is going towards the 30. And let's congratulate Astra on their recent news about stopping their CKD trial because of the benefit on the improvement arm with the use of the dapagliflozin. So we will strict our self to our recommendation by our local authority in what number of EGFR we will be using this class.
Thank you, Dr. Ali, for this comprehensive answers. And this was all the questions for our speakers today. Finally, at the end of this event, I would like to thank every one of you again, professors. Thank you, Dr. Ali. Thank you, Dr. Abdul Masood. Thank you, Dr. Abdul Qawi, for your time and these comprehensive lectures. And finally, again, also, I would like to thank all the online attendees from Saudi and the Gulf countries for attending this live event. And one final message for them, please stay safe and stay at home. Thank you very much.
Thank you, Mohammed. We enjoyed the talk so much from Dr. Abqawi, Dr. Ali, and enjoyed the event today. Inshallah, we'll be back soon to our regular work, and COVID-19, it will, inshallah, will resolve without any major events for all of us.
Inshallah, Dr. Inshallah. Thank you, Dr. Abdul Masood.
Thank you very much. I do
Thank you, Dr.
share
Ali.
with Dr. Abdul Masood that we would like to go again on our live events because the very much I enjoyed the session, the very much I missed the audience in front of me.
Thank you very much, Dr. Ali.
Thank you.
Thank you very much.
Okay. Assalamu alaikum.
Thank you. Thank you. Thank you.
Assalamu alaikum.
Assalamu alaikum.
خلاص كده